Ms. Joan Pereira, next question, please.
Mr. Deputy Speaker, with your permission, may I and SMS Janil address the COVID-19 related PQs for oral answer 7 to 15 in today's oral paper, and then those filed by Mr. Saktiandi Supaat and Mr. Yip Hom Weng filed for 2nd August, and then PQs for written replies filed by Mr. Zulkarnain, Dr. Shahira Abdullah, and Mr. Sean Huang, please.
Please do.
So I will touch on the COVID-19 situation, healthcare capacity, and vaccination program. Thereafter, SMS Janil will address PQs for our treatment and vaccination plans for children. And if the members who filed tomorrow's questions are satisfied with the answer, you may wish to withdraw your questions. Mr. Deputy Speaker, we are still in the middle of an infection wave driven by Omicron variant BA.5. But over the last 10 days, infection numbers have been falling, and week-on-week ratio has dipped below 0.9 over the last week. We should see the wave subsiding further this week. We did not tighten any social restrictions during the current wave. Everyone went about our lives normally, going to work, visiting families, going out with friends, traveling in and out of Singapore. However, life is not as normal in our hospitals. Without additional social restrictions, our healthcare system is bearing the brunt of the current wave. Healthcare workers have been very busy. Polyclinics and our GP clinics also saw higher patient volumes. So to answer Ms. Joan Pereira, we are indeed promoting the use of telemedicine for mild COVID-19 cases. And it is now a lot more accepted by patients than before. But even so, we need to be realistic that in a big infection wave, the healthcare system will come under stress, notwithstanding the common usage of telemedicine. So waiting times at private clinics, polyclinics, hospitals will inevitably go up, and I seek the patience and understanding of all our residents. In such a situation, the key is to ensure that hospitals are not overwhelmed and that those who need urgent care can be attended to promptly. By and large, we have been able to achieve that. The first important measure to achieve that is to set aside sufficient bed capacity to cater to COVID-19 patients. So in response to Mr. Louis Chua, based on our worst-case scenario projection for the current wave, we have plans to set aside up to about 1,000 COVID-19 hospital beds for COVID-19 patients. And this is a dynamic plan, and fortunately, in the course of this infection wave, we did not have to activate all of those beds. In the same question, Mr. Louis Chua asked about foreign patient arrivals for the last 5 years. I think this is a non-COVID-19 related questions. We'll answer it separately, and SMS Janil will touch on that. Second, we ease the workload of hospitals by transferring lower-risk patients to COVID-19 treatment facilities and discharging long-term stayers back to community care facilities like nursing homes. Many of these facilities and services are run by private or social sector providers, and we are deeply appreciative of them for doing this work. Compared to the last Omicron wave, the transfer processes are now a lot smoother, and patients and their families have also become a lot more understanding when hospitals say your loved one needs to be transferred. As a result, for this infection wave, we have been able to make many more transfers than the last, and this has made a significant difference to the workload of hospitals. Finally, hospitals also have to manage their own demand for beds. They have cut down on business as usual workload by about 5% and comprises mostly elective surgeries. This is not ideal because it builds up the backlog of work which have to be attended to eventually. However, the 5% cut today is far less than the 15% cut that we have to implement during the first Omicron wave in the beginning of this year. Hospitals restricted but did not suspend visits to patients. We also did not suspend the leave of healthcare workers so they can still take breaks, including flying to their home countries to see their loved ones and their family members. And this is extremely important in maintaining the morale of our healthcare workforce. Mr. Yip Hong Wing asked if hospital-acquired COVID-19 infections is contributing to a bed crunch. The answer is no. Absenteeism in hospitals due to the current COVID-19 wave has been lower this time round at about 2%. As far as we can determine, while there had been some transmission within hospitals, overall hospital-acquired COVID-19 infection has been low and very likely lower than community-acquired infections. And this is because of good infection control measures in hospitals. We need to recognize that bed crunches are mainly caused by high case numbers in the middle of because of an infection wave, and how those case numbers translate into severe illnesses that need hospitalization. There are only two ways to minimize this. One is social restrictions. Two is ensure good coverage of vaccination amongst the population. All of us do not want to bring back social restrictions as far as possible. The rule of 5, rule of 2, we try to avoid that. And so, therefore, we need to rely on vaccinations. In this regard, like many Singaporeans, I'm very proud that Singapore has achieved what many countries want to achieve, which is most people have gotten up-to-date vaccinations. The resilience has been further strengthened as many people recovered safely from COVID-19 infections. Mr. Seah Keng Ping asks, what percentage of our population has been infected? On record, we have about 1.7 million reported cases, which is about 30% of our population. We also, MOH, also systematically monitor blood samples from routine polyclinic cases and other healthy volunteers for signs of previous infection. From these samples, we estimate about 60% of local residents are likely to have been infected with COVID-19. Notwithstanding, this does not confer us herd immunity. By and large, scientists around the world do not think herd immunity is achievable because the virus will continue to mutate, escape the protection of vaccines, and then infect people. What is achievable is population protection against severe illnesses through vaccinations. And this is what enables healthcare system to weather through an infection wave, even with high case numbers, because the translation of case numbers into severe illnesses is very low. During the last Omicron wave at the beginning of this year, 2.4% of infected persons needed hospitalization. During this wave, 1.9% ended up in hospitals. The actual percentages are likely to be lower because not all cases are reported. Notwithstanding our strong resilience due to good vaccination coverage, MOH still have some concerns, and we can never be complacent. First concern, coverage of the vulnerable, especially our seniors. To get good vaccine protection against severe illness from the Omicron variant, we need 3 doses. It's no longer a 2-dose vaccination, it's 3 doses. However, we have more or less hit a plateau. There remains 40,000 seniors aged 60 and above who have not received their booster shots, even though they are eligible. Another 40,000 seniors have not completed 2 doses yet. So all of them are vulnerable to severe illnesses if infected. And we will continue to try to reach out to them through our mobile vaccination teams, through our home vaccination teams. Second concern, MOH know that vaccine protection against severe illness will not last forever. So Mr. Sean Huang has therefore filed a very pertinent question on when this will start to wane. MOH monitors this data closely. Mr. Deputy Speaker, sir, with your permission, may I show some graphs on the screen, please?
Please do.
Thank you. Yeah. So top left-hand corner, this line shows vaccination effectiveness against severe illness. Top left-hand corner is for the age group above 80. Top right-hand 70 to 79, bottom 60 to 69. And you can see that the graphs are not dipping. In fact, they are staying at a high level, and that is 10 months worth of data. So our empirical data shows that after 10 months, the protective effect of 3 doses of mRNA vaccines remains very strong in preventing severe illnesses. That is why, as of now, our recommendation is for those who are 80 and above to receive their second booster or a 4th shot to better protect against severe illness. Members will notice that top left-hand corner is the chart for those above 80. In fact, it has not dipped, but in general, the protection level is lower than younger cohorts, which is why we recommend that they take a 4th shot or the second booster. As for those aged 50 to 79, although the protection levels continues to be strong, this is also the age when chronic illnesses start to set in. So they have been offered the second booster if they want to take it, either because they are traveling or they are worried about their health because of underlying chronic illnesses. Our experts are actively studying the benefits of a 4th shot or second booster for the age group 60 to 79. In further reducing the likelihood of severe illnesses, we will announce their recommendations once ready and shortly. As for the younger individuals below 60 years old, they have the protection of both the 3rd shot as well as age. And currently, they do not require a second booster if they are healthy. MOH will continue to study the emerging data, including the benefits of newer vaccine formulations, weigh against the risk of new variants, and update our recommendations as and when necessary. Ms. Joan Pereira asked about incidence of reinfections. It does occur, but by and large, reinfection rate during the current wave has been low in Singapore, and we recorded reinfection rates that are lower than many countries. This is likely because we have good vaccination coverage and that we just went through a fairly large BA.2 wave just at the beginning of this year. MOH has been watching the reinfection numbers very closely because it will inform us of the likely timing of future waves. Our observation is that for those who were infected over the last 3 months, the chance of getting another infection is very rare. For those infected 4 to 7 months ago, the probability of getting infected again is about 3% that of an uninfected or naive person. And if you have been infected with Delta variant last year, the probability of getting infected again is about 20% that of an uninfected or COVID-naive person. Of course, this picture will change as time goes by and the protective effect of prior infections will wane. Hence, having been infected by COVID-19 before should not be a reason to let your guard down. In the meantime, reinfections are taking place, albeit not as frequently in Singapore compared to other countries, but they are likely to increase as protection of prior infections wanes. We should therefore start to include reinfection numbers in our daily reported case counts. In the past, we report the number of patients who have been infected every day. So a patient who has been infected twice, we count them only once, and there are very few of them. And with more reinfections from today, we will report the infection episodes instead of infected persons. And this will be a more accurate reflection of the pandemic situation. Mr. Zulkarnain asked about COVID-19 therapeutics. All polyclinics and more than 130 participating PHPCs can prescribe oral antivirals to clinically eligible patients in the community. To date, more than 3,200 patients have been prescribed such therapeutics across different healthcare settings. It is a small percentage of all infections, reflective of the fact that the vast majority of infected cases are of low risk. Mr. Saktiandi Supat asked about the flu subsidy scheme. As at end FY 2021, the government has spent about $178 million on the scheme for over 11 million attendances at private clinics and polyclinics for the treatment of acute respiratory infections. As we progress Towards living with COVID-19, Singaporeans have become familiar with exercising social responsibility through self-testing by following Protocol 123, by keeping ourselves healthy, getting up-to-date vaccinations, and then with employers, education institutions not always insisting to see MCs, most COVID-19 patients can recover uneventfully by resting at home and seeking care only when needed. Our policies will therefore need to evolve with the state of our preparedness. For safe management measures, we refrain from imposing additional restrictions, even as we ride through a wave now. Likewise, healthcare financing policies also need to start evolving and progressively scale back from subsidy policies that were enacted under exceptional pandemic circumstances. I want to assure members of the House that for residents who see their primary care doctors, they will continue to receive institutionalized pre-COVID-19 subsidies, such as CHARS, polyclinic subsidies, healthcare screening subsidies, etc. PHPCs and polyclinics will also continue to provide government-funded swabs to eligible symptomatic individuals at no charge. Mr. Deputy Speaker, sir, while the current wave is subsiding, and I think the worst is over, it is important that we do not be complacent. As the protection of vaccines and prior infection wanes, the virus will circulate in our society again, and cases will rise. We must anticipate when that will happen and take the necessary precautions, including the most important of all, which is to keep our vaccinations up to date. I've deliberately used the term up-to-date vaccinations rather than a second, third, or fourth booster shots. This is because at some point, just like flu vaccinations, we have to stop counting the number of jabs we have taken and number of boosters we have taken. Instead, we must ensure that we get a jab at a suitable interval, maybe 9 months, maybe a year. And this is something MOH will try to determine in the coming months. As of now, there is no change to MOH's guidance and recommendations. It remains what had already been announced. We need to be alert, too, to the threat of a new variant that is more infectious, lead to more severe illnesses, or evades the protection of current vaccines. We hope it will not happen, but many countries in the Northern Hemisphere are worried about that and worried about what might come out in the coming winter. If we encounter such a variant, I'm afraid social restrictions will become necessary again. Mr. Deputy Speaker, sir, notwithstanding these words of caution, let me underscore the importance of what Singapore just went through. With each wave, we are coping better. We are riding through this current BA.5 infection wave without imposing further social restrictions or imposing border measures. In our hospitals, we imposed fewer restrictions, and hospitals are generally able to cope better than the last wave. That means that the Singapore society, we have taken another major step forward in living with COVID-19 as an endemic disease. And I think this is a big national day present for all Singaporeans. Thank you.
SMS Janil Puthucheary.
Mr. Deputy Speaker, sir, there were several PQs on our treatment and vaccination plans for children. Sir, I was saddened by the recent deaths of 2 young children from COVID-19 and offer my deepest condolences to their families. Based on local and international data, the BA.4 and BA.5 Omicron subvariants have not been observed to affect children more severely than past variants. And severe COVID-19 infection continues to be rare in children, especially amongst those who are vaccinated. For children aged 5 to 11 years of age, a third mRNA dose may be necessary at some point to keep protection levels high, and MOH is making the necessary preparations to roll out vaccination booster doses for this age group in about 2 months' time. At present, the Pfizer-BioNTech Comirnaty COVID-19 vaccine remains the only vaccine authorized for use in children aged 5 to 17 years in Singapore. Children who are not medically eligible for the Pfizer-BioNTech Comirnaty COVID-19 vaccine may receive the Sinovac Coronavac vaccine under a dedicated public health program, while Moderna's vaccine for this age group remains under evaluation. Children under the age of 5 are currently the last group not yet protected by vaccination. MOH is preparing to start vaccination for those under 5 towards the fourth quarter of this year. The Health Sciences Authority, HSA, is currently reviewing the data submitted by Pfizer-BioNTech and Moderna on their COVID-19 vaccines for this age group. We will provide an update when an assessment of the quality, effectiveness, and safety of the vaccines has been completed. Members asked what could be done to detect, diagnose, and treat COVID-19 in children. Currently, children under the age of 5 remain more vulnerable to COVID-19 infection and have higher rates of severe outcomes as compared to older children. This is similar to other respiratory diseases. However, the overall incidence of severe outcomes from COVID-19 infection remains much lower amongst children compared to adults and the elderly. Children needing medical attention should be seen by a GP or a polyclinic if unwell. And the clinical teams, the doctors there, will test children with ARI, acute respiratory infection symptoms, using an antigen rapid test, an ART by default, or a polymerase chain reaction PCR test if indicated. Children under 3 months of age are admitted to the hospital by default, whereas older children are treated under the home recovery program and reviewed by doctors via telemedicine. This service is available round the clock. Our hospitals continue to prioritize care for children with urgent medical conditions, and those who require further observation and treatment will be admitted. MOH regularly reviews and updates the screening and review criteria with inputs from a panel of specialists. Oral antivirals are licensed for use under the Health Sciences Authority's Pandemic Special Access Route for patients aged 18 and above only. For children aged between 12 to 18 years, local and overseas treatment guidelines indicate that Paxlovid may be considered on a case-to-case basis. We will continue to review the evidence for the use of oral antivirals for children under 18 years of age. We'll continue to monitor the incidence of severe illness and deaths due to COVID-19 closely and adjust our processes to protect our healthcare system and our patients. We ask everyone to take the necessary precautions and remain socially responsible by self-testing if unwell, getting vaccinated and boosted, and avoiding social interactions if you have a fever or respiratory symptoms. Lastly, sir, to address Mr. Louis Chua's question on foreign patients, the number of foreign patients who come to Singapore to specifically seek inpatient treatment or day surgery at our hospitals has historically been small. Between 2017 and 2019, our public and private hospitals saw about 32,000 foreign patients annually, or about 3% of all inpatients and day surgery patients. These numbers have since fallen by 80% compared to pre-COVID levels. In 2021, there were just 6,000 episodes, comprising less than 1% of total cases seen in hospitals. Thank you, sir.
Ms. Joan Pereira.
Deputy Speaker, I have two SQs for Minister Ong. A recent study from Portugal suggested that the currently dominant Omicron BA.5 subvariant is linked with higher odds of causing reinfection, regardless of the vaccination status. Is the ministry considering conducting such similar studies, and would such findings affect our country's vaccination and treatment strategies? Thank you.
Minister Ong.
Thank you. I heard only one question. I'll try to answer them. As I showed the data, as I reported just now, MOH likewise is monitoring empirically the rate of reinfections in Singapore. And by and large, our rate of reinfection, we notice, is lower than many other countries. We are at a stage where every country's experience is different because they experience different waves with different dominant strains, with different vaccination and booster rates, and in combination, and also different age profile, old and young. So when you take all that into account, every country's experience is now unique. We note the Portugal's experience, and in fact, Portugal and now Australia are undergoing, Portugal has gone through a wave with many hospitalization. Australia is undergoing a BA.5 wave with many hospitalization. In our case, due to a combination of factors, high vaccination rate, high booster rates, the fact that we recently gone through a BA.2 wave, which give better protective effects against BA.5, we have weathered through this current wave much more smoothly than compared to Portugal. We will continue to monitor reinfection rate. As I mentioned, what is important is whether reinfections or infections translate into hospitalization. So what is important is vaccination effectiveness against severe illness. We monitor that closely, as I mentioned, and I showed in the chart earlier. After 10 months, protective effect is still strong, but we'll monitor closely.
Mr. Saktiandi Supat.
Thank you, Mr. Speaker, Deputy Speaker. I'd like to thank our Minister for his answer earlier with regards to my question scheduled for tomorrow. I have two SQs which is related to the question that probably Minister didn't get a chance to answer in my PQ, which is first, whether the flu subsidy scheme has actually encouraged more eligible residents to seek medical treatment. And one of the reasons why I asked the PQ for tomorrow is because some residents have come up to me, the flu subsidy scheme, they found to be useful, especially in the current context of costs rising. The second question, in regards to the deactivation of the scheme, whether it will hamper early detection of efforts in terms of data collection for MOH as well, in terms of COVID-19 going forward. Thank you, Minister.
Notwithstanding deactivation of the flu subsidy scheme, as I mentioned, the current subsidy schemes continue, especially if CHARS, polyclinic subsidies, continue to be there. Does the flu subsidy scheme enhance the number or increase the number of people seeking medical treatment? I believe that is a reasonable effect that we should expect of any subsidy. Yeah. On the other hand, and I think in the community we have probably all met residents who say there's a flu subsidy scheme, it costs $10, no harm. I think I might have COVID, just go to the GP. Yeah. When they are also very well, young, and probably can recover uneventfully at home, drinking more water, rest, taking ART. So I think to have a subsidy scheme like that, on one hand, more people may come forward. On the other hand, you can also overcrowd the GP clinics. And as we enter into a phase where we are more prepared and better able to live with COVID-19, we should also, just as we wind back on our SMMs, we also need to go back to the subsidy scheme that is pre-COVID-19. And that's what we are trying to do for one of our smaller schemes, which is flu subsidy. Hospitalization, testing, all this continue to be fully subsidized. And that is an even larger amount that we continue to support. Will this therefore reduce the detection rate of COVID-19? I think a lot depends on self-testing, much more than GP testing. You can now use telemedicine, as Ms. Joan Pereira say. Using telemedicine, test in front of a camera on Zoom, and the doctor can record it in the system. So I think by and large, people know how to use the system, and we continue to be able to monitor our epi curve with the reports from people very promptly and quite accurately.
Mr. Leon Pereira.
Thank you, Mr. Deputy Speaker. Just three supplementary questions for the Minister of Health. Firstly, he shared some data on the mRNA vaccines being effective, 3 shots against seriously falling ill. Could you give us a sense of that data for the non-mRNA vaccines, the traditional vaccines? Is it less efficacious than the mRNA? Second SQ is, would MOH consider sending mobile vaccination teams to individuals' homes to vaccinate them, even if they're not seniors, if there are strong mitigating factors? For example, if the individual is diagnosed with a mental health condition that makes it hard for them to leave their home. And a third SQ is, would the ministry consider tweaking its systems and processes to encourage people who go in for the COVID vaccines to also get a regular flu vaccine at the same time, if indeed that is scientifically feasible? Thank you.
We have a few non-mRNA vaccines. Novavax has shown to be efficacious in preventing severe illnesses. The other two, slightly less. I don't have the data, but the data has shown that it's slightly less. Not just us, but Chile, Malaysia, other countries have also published similar data and made similar observation. Having said that, they do have a protective effect. Having those vaccination is better than not having vaccinations. So please encourage residents to take them. As for mobile vaccination for those who are not seniors, we will do so, and we have been doing so. If you come across any residents that need them, can always raise with MOH, and we'll assess and try to be as helpful as we can. Do we administer flu vaccines together? In practice, we can. But unlike many other countries where there is 4 seasons and there's a winter season and a flu season, they find it useful to administer flu vaccines and COVID-19 vaccines concurrently, which is what Australia is doing currently. And towards the fall, many Northern Hemisphere countries intend to do so. We do not have a flu season. It comes and goes, could be any time. So it's harder for us to combine 2 vaccinations at the same time because of the lack of flu season. But theoretically, it's possible. And if someone wants both together, we should think of a way to administer both.
Mr. Sia Kemping.
Just 2 supplementary questions for the Minister. First, Minister mentioned that the 60% infection, the current 60% infection doesn't accord us herd immunity. Just like to ask him at what level would we consider that we have herd immunity. My second SQ relates to the seniors. I'm surprised that, well, I'm not surprised, or rather I would say that I'm concerned that there's 80,000 of our seniors who either have not gotten their second vaccination or that they have not had the booster jab. 80,000 seniors is a lot of people. And I know we are still trying to reach out to them through our mobile vaccination teams. I think that would take too long. I mean, we've been trying that for quite a while. I think to cover the entire 80,000 would take a long, long time. So my question is, what other solutions are there beyond the current mobile vaccination team? Thank you.
I'm sorry to disappoint Mr. Sia Kemping, but even if we hit 100%, we will not have herd immunity because it's no longer a function of percentage coverage of vaccinations or infections, but it is the fact that it is a fast mutating virus and it will escape prior infections protection as well as vaccine protection. So therefore, do not aim for herd immunity where we think the virus will disappear, but instead live with the virus but protect ourselves against severe illnesses. What other solutions are there? Mobile teams have been useful. Home vaccination teams has been useful. 80,000 is a big number. But on the other hand, compared to other countries, we are 93% covered by vaccinations, 79% covered by booster. It's very, very high by international standards. We'll continue to try hard. But I suspect, especially the 40,000 seniors who have not even taken 2 shots, they must have deep personal reason not to do so. For the other 40,000 that have taken 2 shots but somehow have not taken booster, I'm a bit more sanguine because they have taken 2 before. I think you can persuade them to take a third. But those who have not taken, and I think we met them and we tried to persuade them, and it's difficult. So I think the better way now is for us to be considerate that there are such vulnerable seniors amongst us. So we must always exercise our social responsibility. If we don't feel well and we are meeting one of these seniors, avoid meeting them or test yourself before you meet them. In other words, the rest of us who have been vaccinated or been infected, we have to protect those who are not protected and are vulnerable.
Mr. Dennis Tan.
Thank you, Deputy Speaker. I just want to seek clarification from the Minister regarding my question 13, Part B. I'm not sure I heard the answer. Will Singaporeans who are under 50, if they wish to take the second booster because of travel requirements or because of concerns arising out of travel, will they be allowed to do so under the national vaccination program? Thank you.
Currently, our rules do not provide for that. If you are below 50, you have taken 3 shots already, and you are healthy, our rules do not provide for them, and they wouldn't be offered. But if they have underlying conditions, they suspect they are sick, they let us know, we will offer it to them. The reason is, as I mentioned earlier, protection against severe illness is what's important, and it continues to stay very high, especially if you are young. And towards year end, we don't know what's coming our way. In the Northern Hemisphere, many countries are worried about new variants. So therefore, sometimes it's also worthwhile to keep our powder dry, especially for the younger group.
We'll take last 2 questions on this topic. Mr. Yip Hon Weng and then Mr. Louis Chua.
I thank the Minister for his reply and his response to my PQ slated for tomorrow on hospital-related infections. I have one clarification for the Minister and whether his response on hospital-acquired infections include our community hospitals and nursing homes, because many of the patients there are seniors and vulnerable patients. Thank you.
Yes, it does, and thankfully, we have been able to keep our nursing homes safe. It makes all the difference, and we'll continue to try hard to protect our nursing homes and community hospitals.
Mr. Louis Chua.
Thank you, Mr. Deputy Speaker. Just got one SQ for the Minister. So on the 9th May, a report in the Straits Times, one of the private hospital groups shared that it has stood down its ring-fence general ward capacity. So I note from Minister's response that about 1,000 hospital beds are being set aside for COVID purposes. So just wanted to understand the healthcare system today across both the public and private hospitals, what is the current level of bed utilization as a whole? And if the need arises, where would these additional 1,000 beds come from and how quickly can they be activated? Thank you.
The 1,000 beds I mentioned refer to public hospitals only. If we include private hospital beds that we can acquire, there's another couple hundred more. I can't remember the number. Today, hospitals are busy, not because of COVID patients, but a lot of business as usual patients. 90% occupancy is quite common. And this is after taking into account setting aside some beds for COVID-19 patients. As I mentioned, it's a dynamic plan. When we see a curve going down, numbers going down, we may release more beds. When we see the epi curve going up, we may take up more beds and inch towards the 1,000 beds. So it's a dynamic plan. But what's important, what I mentioned, is that this wave, we managed to ride through it. And I think the worst is over. We managed to go through it better prepared and better respond than the last wave.
Because the presentation of the petition took 6 minutes, I've been informed that PQ time will be extended to 3:06 p.m. So I think we can carry on with the PQs.